I'm going to talk about a paper that we did, but I want to wrap it in a little bit of context before I do that. That's the complicated long name of the paper, Associations Between Organizational Communication and Patients' Experience of Prolonged Emotional Impact Following Medical Errors, which basically means how we communicate with people afterwards has implications for their outcomes and how they do. And so we're going to talk about that. We're going to dive in a little bit. I have no disclosures, and I also just want to start with some acknowledgments and thanks, because what I'm presenting is the work of many, many people. So thank you, Melinda and the Betsy Lehman Center, for this opportunity, and also just for our ongoing partnership. It's a real pleasure to be able to learn from you and partner with you. The IHI and the Lucian Leap Institute offered us access to their data, which formed the basis for our sub-analysis, so I'll talk more about that. My co-authors, especially Sigall, who's here, and Tenzin, who I believe is in Nepal now, who really made the paper happen. Without them, it wouldn't have happened at all. And the BIDMC Center for Healthcare Delivery Science, which supported the analytical resources that we needed to be able to do this project. So again, really presenting on their behalf. So some objectives for today: we want to talk about the types, severity, and duration of harms that patients can experience because of their healthcare. And much of this, what I'm going to share, is going to be a review for many of you, but for those that aren't as familiar, I think it's really important to understand it's more than just physical harm. There's a lot of non-physical harm, so we'll talk about that. We're going to talk about the impact that CRPs, communication and resolution programs, care programs, can have on those harms, because I think that's a really interesting topic to be thinking about, and one that's strategic for being able to implement these more widely. And then we'll talk about next steps and the implications of that as we go forward. So Melinda sort of set us up beautifully for this, but CRPs really are best practice. I think there maybe was some debate about that for a while, but these are all the entities that recommend CRPs or strong components of them. Joint Commission, National Quality Forum, Leapfrog, U.S. National Steering Committee for Patient Safety, the WHO, all recommend proactive approaches to communication after unexpected events. The 2023 PCAST, President's Council of Advisors on Science and Technology, specifically called out CRPs as an important patient safety intervention. The CMS Patient Safety Structural Measure that Melinda mentioned also specifically calls it out. Out of the 25 attestation statements, 2 of them are about CRPs. And the AHRQ with its Candor Toolkit, but also through a recent literature review, the QR code's there if you're interested, also supports implementation of CRPs. And yet, we know that implementation is inconsistent. Just like Melinda said, this is one of the big challenges in the field. So why is that? If this is a good idea, if the evidence is clear, why are we not using them reliably, implementing them reliably? There are probably 4,000 plus hospitals in the US. If 400 have it, great, but that's 90% that don't. So why? And that's really what we're going to talk about today. And one of the things I want to suggest to you is that a contributor to why we haven't gotten there yet is that strong evidence of effectiveness, meaning for patient, family, and clinician-centered outcomes, hasn't really been available to us. We've got a strong anecdotal evidence. I was talking with Carolyn earlier today, and those of us that are a part of this program, and Linda earlier today as well, we were talking about how we know that this works. You see it on the case-by-case basis, and that's very convincing for those of us who've been part of it, but data are needed to convince larger groups of people, and we need better, stronger data in this regard. Most of the good research, the rigorous research, has been about organizational outcomes, cost, medical legal experience, not about these outcomes. So I want to start by talking a little bit about the tail, the story, and also the long tail, the long duration of harm from healthcare. The data I'll share here just give a little bit of a flavor, and then we'll bring it back to Massachusetts, and I'll show you some Massachusetts data. So this study, our data collected a number of years ago, talking with patients and families who'd experienced errors in their care or adverse events at least 5 years ago. Some of them had experienced it longer ago. And they asked them, well, what are you experiencing from that? And about 2/3 said lasting physical impacts. Not surprising. We know that there's a serious physical impact from harm events. But they also described a lot of non-physical impacts. Altered view of their life and of themselves. Vivid memories, 50% with a loss of trust in healthcare. 50% angry, grief, psychological scars, almost 1/3 with financial impacts, 1/3 with altered healthcare seeking behaviors, meaning they might be less likely to engage, less likely to come to a follow-up appointment, which might have implications for their physical health going forward, as you can imagine, and many still with self-blame. And I think for me, when I saw these data, they really opened my eyes. Wow, there's this whole bucket of non-physical harm we haven't been thinking about, haven't been measuring, and is really important for people's lives and for their future physical health. And I also just want to, apart from the diversity of harm here, there's also the duration of it. While about 70% of these interviews were with people whose harm event had happened 5 to 9 years ago, about 30%, it had happened 10 or more years ago. And they're still having these effects. I mean, that's an incredible duration of effect from this event that occurred. So let's bring it to Massachusetts. And I think recognizing there are these different buckets of harm, the physical injury, the emotional and psychological that we talked about, but also socio-behavioral, which is maybe not the most intuitive of names, but it means that when these events happen, it affects our relationships, our social interactions, and our behavior, especially around healthcare seeking behavior, and financial, both the direct costs and the indirect costs when it alters our life and we're not able to work anymore, or we have to hire caregivers or whatever it might be. So this is a lot, and these data really that I'm about to show you are from the Betsy Lehman study here in Massachusetts, asking Massachusetts residents, have you had experience with an error in your own care or the care of someone close to you? And what's happened with you? And so we see that a significant proportion, the patient had actually died, and about 20% had a strong impact on their physical health for more than a year afterwards. For those whose errors were 3 to 6 years ago, significant proportions were still depressed, abandoned, betrayed, or angry. Socio-behaviorally, the effects were even stronger. 57% were avoiding the doctor and the facility because of what had happened. 67% remained less trusting of healthcare. 37% avoiding medical care overall. The effect is extending beyond where it happened to all of healthcare. You can imagine the physical effects on physical health for folks who need to be seeking care and yet now are actively choosing not to because of how bad the experience was. And financial is huge. 50% with increased medical expenses, a third with increased household expenses or a decrease in income. So it's a lot, right? This is a lot of harm. And we know that. And we know that there's a lot to think about there. So we're going to do some audience polls today. If you have a mobile device with you, go ahead and grab it. You can scan the QR code with the camera. If you don't have a mobile device and you're on a web browser virtually with us, go ahead. You can go to slido.com, just a web page, open up a blank web page, type in slido.com and enter that 7-digit code. And then you'll be able to participate in the poll here. And you should only have to log in once, and then it will just refresh for the subsequent questions that we do. And how many folks online do we have today? Just ish?
34.
34, good. So see a bunch of people voting. We'll give a moment for more folks to log in and be able to vote. But I'm curious, what is the most striking part of these data for you? When you look at these data, is it the duration of harm, how long it lasted? Is it the proportion of people that suffered such harms? Is it the types of harm, the severity of harm, or something else? What sticks out for you? This is great. Thank you for everyone who's participating in voting. It's awesome. I think it's pretty clear the duration of harm is a big deal, right? For 2/3 of you, that's really what's sticking out the most. And I'll be honest, for me, I think that was one of them too, was how long the tail of harm is after these events occur. So thanks. We'll have more polls. They'll be able to log in on the future ones if you haven't already. So this is sort of the equation that I want to think about today with you all. Harm events happen, and we know that they lead to harm to patients. And we just talked about these 4 different categories of harm. We also know that these same events have impacts on families and on clinicians and on healthcare organizations. And we're not really diving into that today. We could talk about that forever as well. But really what we're thinking about now is, okay, that's happening. How are we responding? Are we responding with a CRP approach, a care approach, or something else? How is our response affecting the outcomes in the long run? Is it making things better? Is it leaving them unchanged? Or is it making things worse? That's really the fundamental question. And we hope and we think that it's making things better, but we need data to be able to prove and show that if we're going to get people to start responding better. So that's what we really dove into. So I want to ask you, before I show you some data, how much do you think CRPs affect patients' emotional outcomes? Because that's the bucket we're going to think about today, is the emotional piece. Slido uses these funny little emoji faces. So the The crying faces worsens a lot. The happy face with the heart eyes is improve a lot. But where do you think this falls? In the middle there with sort of the straight line mouth, that would be that they leave things unchanged. So where do folks think that how much do CRPs make a difference here? I'll give a moment just for folks to vote, but I think we're seeing the prevalence already is that they seem to probably make them better is our sense, but not necessarily a lot. And so that's really the question. How much of a difference? Great, thanks for voting. So, let's see what the data shows. I'm going to start with Australia. So Australia is really interesting. They actually enacted a national open disclosure policy in 2002. Each state in Australia, this is from New South Wales, NSW, does it probably a little bit different way. This is what they describe as being in their open disclosure policy, and there's a lot in there, but I'll basically call out it's essentially a CRP approach. It's proactively acknowledging it in a timely fashion, talking about it, apologizing, caring for people and supporting them, including the providers, improving patient safety, and really doing this in a multidisciplinary process in all the ways, right? So that sounds like a CRP to me. So they actually did a survey in this state and they asked people, well, how did you have a bad event? And if you did, what was the nature of the organization's response? Did you get this open disclosure or not? What was the effect on your outcomes there? And so the data suggests, if I can get it to advance. There we go. That it actually makes things better, right? So they asked about a couple things. They asked about some bad feelings. Did you feel angry or did you feel depressed? Those who didn't have open disclosure had 56% felt angry, 45% felt depressed. And if they did have open disclosure, 33% angry, 41% depressed, right? So slightly better numbers, only one of those was significant. They also asked about good feelings. Did you feel relieved to know what had happened? Did you feel you were confident that you were in good hands? Did you feel satisfied with your treatment? And they saw corresponding increases in those good things based on whether they had open disclosure or not. So beginnings of some signals that maybe this CRP type approach is actually leading to better emotional outcomes for patients. All right, so that's Australia. What about Massachusetts? I think you've all seen this data that were probably presented here not that long ago. Similar thing, surveying Massachusetts residents. Do you have experience with an error in your own care or in the care of someone close to you? And if you did, then what was the nature of the communication by the organization afterwards? Was it open communication, which is the blue line, proactively talking about the event, accepting responsibility, apologizing, all the things that are part of care, or was it without open communication, the orange line? And as you can see, the rates of feeling abandoned, betrayed, sad, depressed, angry, avoiding the doctor, avoiding the facility, notably different in those who didn't get the open communication. So slightly different questions, a little overlap with Australia, some additional factors to be thinking about, but really quite a marked difference. Every time I see these data, I think, gosh, that's a really big difference between those two lines. So it's in that context that we thought, okay, this is good, but can we get more data? We want to be even more convincing, and this is just one state, and we've got Australia, which is a little far from here. So can we build out a little bit more evidence behind this? And so we turned to some national data. The QR code here is for this report. This was produced by IHI and NPSF when NPSF was a separate entity. It was research conducted by NORC, which is a research organization at the University of Chicago. And they surveyed very rigorously a very representative sample of Americans. And this is from a number of years ago, I think 2017 is when they published. They surveyed about 2,500 Americans and they asked them many questions about patient safety. But one of them was, do you have experience with an error in your own care or in the care of someone close to you? 40% of people said yes. 40% of Americans. And so that's like 1,000 people. And then they asked those 1,000 a series of questions about, well, what were the negative effects and what was the nature of the communication? So this is what they found in terms of the negative effects, pretty similar to the other numbers I've been showing you. We've got 4 different buckets here: physical health, emotional health, financial well-being, and relationships with family. And you can see, for example, with physical health, that 30% described having a permanent effect on their physical health as a result of that event. 27% with a long-term effect, 27% with a short-term effect, and 15% with no effect. So you can see large percentages for all of these. The one we're really going to be thinking about today is the emotional health piece. That's the data we really honed in on and wanted to understand. Did the way that organizations communicate affect the amount or the duration of emotional impact that they had afterwards? And you can see there was pretty significant emotional impact across the board. They then said, okay, well, after that event happened, did the organization talk to you about it? Did they disclose it to you? Or did you or somebody else report it to them? Meaning, was there opportunity to have some communication with the organization? And if so, then they asked respondents these questions, and this is a selection of the questions they asked. Did someone speak openly and directly about the error? Did someone apologize and take responsibility? Or did they actually deny responsibility? Were they secretive? Did someone refuse to apologize? Did they try and prevent you from getting the information you needed? What was the nature of the organization's response? And you can see there are pretty significant proportions here who had these different experiences. So what we did is we said, okay, we want to do a sub-analysis. We want to hone in on those who had that kind of communication and had this effect on their emotional health, and we want to understand better those associations. So this is the paper that I'll be showing you the data from today. Some of the co-authors are here, Sigall, of course, Pat Focarelli here as well, and thanks to the other co-authors. So what we did is we first defined our subpopulation. We said we want people who have a personal experience, so not in the care of someone close to them, but who are actually reporting their own personal experience so that we get really a good recall of what happened. They have to have had their experience at least a year ago, because we want to know, we want to be able to normalize for how long ago the error was. If the error was a week ago and they're saying they have a permanent effect, well, do we really know how long that's going to be for? Not really. But if every was at least a year ago and they're saying they have a permanent effect, we know that it's at least a year that they're having. So that was actually important to us. And they needed to tell us whether they were having emotional impact, and if so, how much. Turns out that was about 450 people out of the 2,500 that completed the original survey. And it's really that 451 that we're looking at for the rest of the data that I show you. This is that population. They were mostly female, about 61%. They were about 52 years old on average, mostly white, but there were significant proportions of Hispanic, Black, non-Hispanic, and other race ethnicities. About 13% spoke a language other than English at home. And about 16% had a low socioeconomic status. And we're defining that here as household income less than $50,000 a year and less than a high school education. And that'll come up in the results that I show you. And about a third said they had fair or poor physical health at baseline. For this group, 31% said that they had more than 1 month of emotional impact, and a separate additional group had 20% had impact lasting more than a year. So pretty significant emotional impact for us to be looking at as a result of these events. There were lots of different types of errors that they have experienced. We won't get into this a lot today. Really, you can see diagnosis and treatment-related errors were the most common. That's probably not surprising to those of you who work in patient safety. We know that diagnostic and treatment errors are the big ones. But interestingly, about 57% described that part of what went wrong for them was that they experienced disrespect. They had a problematic interaction with the healthcare system, whether it was communication, coordination, something else, and that contributed to the event. We could talk for a while about that as well. It's a whole interesting area. But there were many different causes for these events that we're going to be talking about. And then about 53% of them had some sort of physical impact that was more than minimal. So multifactorial effects from these events. The important part of one of the trickiest parts of the paper, I'd say for us, was figuring out how to categorize this organizational communication with patients. When we communicate, it's not just we did it well or we did it poorly. It's a little bit more nuanced than that. So how do we begin to bucket things so we can understand associations between different communication and different outcomes at the end of the day? So this is how we did it. As I mentioned, folks who reported an error in their care were asked 2 questions. Did someone inform you that an error had been made, or did someone talk with you about that or not? Or did you report it? Or did someone report it on your behalf or not? And if they said yes to either of those, yep, someone talked with me and it got reported, or it got reported, then they would be asked a series of questions. But if they didn't, we started to put that in a bucket of, no, there was no organizational communication about the event. They didn't disclose it, no one reported it. That's actually its own experience, right? So that's one bucket. There'll be 3 more buckets I'll show you. So that's one. If they did say yes to either of those, they got asked these questions. And for each of these questions, we then decided, was that action by the healthcare organization, that communication, was that consistent with guidelines about how we should be communicating aftercare? So as we know from CARE, CRPs, Candor toolkits, someone should be speaking openly and directly about the error. So that would be consistent with the guidelines, right? Someone should be apologizing and taking responsibility. That too would be consistent. These others, where someone's refusing to apologize, being secretive, denying responsibility, preventing information, those are all contrary to guidelines. And then we created some more buckets. So we said, okay, if people said yes or no to each of these questions, and if they said yes just to the ones that were consistent, well, then they got good communication, right? It was just what was supposed to happen. If they got some communication that was consistent and some that was contrary, they would end up in a mixed bucket. They kind of got a bit of both. And if they got just the contrary, no good, nothing consistent, then they were in the bad bucket. So those are our 4 buckets: no communication, really good communication, mixed, or bad. So now I'm going to show you some outcomes. This is what we found. This is the crux of it. So what you're seeing here are odds ratios. Odds ratios means how many times more likely are you to have the bad outcome. And the bad outcome we were interested in was more than 1 year, prolonged emotional impact. So if your odds ratio is 1, you don't have an increased likelihood. 1 times a risk of something is the same thing. But if you have a 2, you're twice as likely to have that bad outcome. If you have 3, you're 3 times as likely. So the higher numbers are worse. And as you can see here is if someone got good communication, they didn't have increased risk. That was our referent group. If they didn't describe it, if they didn't actually answer any of those questions, well, it was about the same. But as we get into these last 3 categories, no communication, mixed, or bad, you see things start to get worse. If there was no communication, they were twice as likely to have prolonged emotional impact. Not talking is associated with worse outcomes. If they got mixed communication, some good, some bad, that was just about as bad. It was still about twice as worse in terms of their risk of emotional impact. But if they got just bad, all the communication was bad, they were 4.5 times more likely to have prolonged emotional impact. How we communicate seems to be strongly associated with outcomes. There were a couple other things we found as well. One was that low socioeconomic status, so again, household income less than 50,000 and less than a high school education, it was independently associated. So even if we did a great job communicating, this was an independent risk factor for prolonged emotional impact. Twice as likely, just as bad as if we hadn't communicated or if it was mixed communication, just by virtue of being in that situation in their lives. And interestingly, if the event involved more than minimal physical impact, that was almost 7 times more likely to have prolonged emotional impact. Those 2 run together. So our main takeaway was the 2 strongest risk factors for prolonged emotional impact were 1, if there was physical impact as a result of the event, it was more than minimal, or if we did not if we communicated poorly against the guidelines, basically. We did look at other factors. You'll see them at the bottom of the slide there. Age, race, ethnicity, speaking a language other than English at home. I know that I expected race, ethnicity, and speaking a language other than English at home to be independent risk factors. It turns out they weren't in our data, and I don't really know why, to be honest. I think this is one of the things that would be worth studying more with bigger populations. As you remember, we started with 451 people, and by the time you whittle down to these groups, you can see the numbers. Some of those groups are starting to get pretty small, so maybe we just didn't have enough data. I don't know. But this is what our data showed. So some limitations, and then I'm going to ask you to reflect on what you think of these results in a Slido. One is that these data are now a little bit older. We're in 2025, 8 years ago. Just a couple things happened between 2017 and now. So whether they're truly representative of our current environment, I don't know. It was a relatively modest original survey response rate, 37%, which is actually pretty good for a lot of surveys, but wasn't, fantastic and large. As I mentioned, we had these small sample sizes, especially for subgroups. The original survey was quite long, had a lot of components, and we weren't involved in the design of it, so we were a little limited in the way that some of the questions had been asked because we were trying to do something that it hadn't been designed for. So that limited a little bit of what we would do, but ultimately, I think we still found something useful. And as many people may be thinking, we're asking people to reflect on events that happened a while ago. How much are they really remembering accurately what happened? And similarly, when they're saying they experienced an error, was it really an error or not? Is anybody verifying that? And what about the communication? Is anybody verifying whether this communication did or didn't happen the way they said? And no, we couldn't based on the way this study was done. So that's a potential limitation. That being said, we know through lots of research that patients' recall of events is valuable and includes a lot that we couldn't get through other sources and is really meaningful. So take that for what it is. So here's that Slido. I'm curious, what from this study stands out most for you? And this is a free text one, so you can just type in a brief phrase or What is it that sticks out for you? And we'll have our panel, so we'll be able to talk about these things, but just want to get some feel from the audience about what's resonating with you when you see these results. Give a moment for folks to respond. Nothing, fair enough. And that may be because this is all, as someone else said, not surprising. Kind of, we expected all this, right? Bad communication being worse, consistent with expectations, impact good and bad. Yeah, that poor communication was such a big deal. Yeah, thank you. This is great. Just getting some sense. So for many of you, I suspect many of you have been in this field for a while. This is actually just sort of validating your real world experience. Yeah, question.
So I was wondering, I'm a primary care physician.
Yeah.
How come you guys didn't look at gender, as like when you were keeping things out? And then I was wondering if you separate caregivers.
Yeah.
Because I think there's also a different experience or perspective, even in their ratios of education and how, and male, female who take care of family members.
Thank you. Great question. So yeah, we didn't look at caregivers because we wanted folks to be reporting their own experience, but I agree it would be a great area to study. We actually did look at gender, and I didn't share those results here. We actually found that female was slightly associated with an increased risk. I don't think we could really explain that. I don't really know why.
Studies that say females tend to seek healthcare a little more too.
Yeah, maybe it's something like that. I didn't have space here to put it up, but yes, I think it would be worth more exploration. Yeah, thank you. So yeah, lots of good thoughts coming up here. I'm sure that as we go through our panel, we'll be able to reflect on these some more, but thank you for participating in this. Great. So some implications. I'll leave us with some implications and then we'll transition to our panel. So implications for implementation. This is what I think as I take away, and then we'll be asking you what resonates most with you. One thing for me that I've begun to think differently about CRPs. I think historically we've thought about CRPs, care programs, as things we do after people have been harmed because it's the right thing to do. And I think that's true. But I actually, based on these data and the other data I showed you, I start to think about CRPs as a patient safety intervention in and of themselves. They are preventing future harm, not just for other patients by making care safer, but for the people who were harmed by the index event, by the original event. And that's a frame shift for me, and I think for many people as well, that this is just like we do other things to prevent harm to patients. We should be doing CRPs to prevent harm to people who've been experienced some sort of medical event. So that's a shift for me, and I think that shifts the way organizations think about implementing these programs. I think that, the issue about are these really all errors is could we confirm that or not is an interesting one. But we also know, just like Melinda described, most of what the care program CRPs involve is communicating with people whose events are ultimately not determined to be preventable, 85% versus 15%. And I think these data, I think that's important when we look at these data, because at the end of the day, does it really matter whether there was an error or not? It just matters what the outcome is. And I think for me, one of the big implications is we probably need to be paying extra attention to vulnerable patients and families. For example, low socioeconomic status. We got to learn more about what's going on there, and can we mitigate those outcomes for that group in particular. For research, I think there's important implications too. We need some larger sample sizes, more diverse populations. It would be interesting, I think, to verify whether there were errors or not. Maybe there are differences between those subgroups. Maybe it's worse for one group versus another. I think, the care program, the care response, the CRP response, it's a multi-component intervention. And we're just looking at the communication piece here, but there's support pieces, there's the compensation piece, other aspects of the response after harm, including an assessment of how those associated with outcomes or not, would be really interesting. I think we need to do more to try and reduce emotional harm no matter what. And I think understanding predictors of other non-physical harm would be great. So we talked about physical, emotional, psychological, socio-behavioral, financial. We didn't study the socio-behavioral and the financial here. I think predictors of that, understanding that, would also be really helpful down the road. And then lastly, I think there's some implications for measurement. This is a paper that we recently published about this issue. How do we measure how we're responding after patients experience harm from their care? So I encourage you to have a look. But I think I would just distinguish between two different kinds of measurement. A lot of the measurement that I'm showing you here, this is measurement for research purposes, and we need more research for sure. But there's also measurement for operations, meaning like organizations that have programs like Melinda described and what Betsy Lehman does and collecting data. How are we actually doing and implementing and using our program? And that kind of measurement, I think there's a need for a lot more measurement there as well. So lots to think about in those spaces. So here's my final poll for you, which is what do you feel are the most important implications of this study? What's sticking out for you as you think about the results that we shared today? Is it that we need to use our CRP more reliably, or we need to talk about how they're a patient safety intervention, we need more research, or we need to do more measurement? And by measure, I mean the operational piece there. Those top two are leading contenders. They're in a race for which one is a bigger one here. But both pretty important is what seems to be coming out. So yeah, we need to just do it better, right? We need to do it more reliably. If we got 10 patients who come in and get harmed, are we doing it for 5 out of those 10, or are we doing it for 9 or 10 out of those 10? How reliably are we using our CRP? And this idea of talking about CRPs as a patient safety intervention, for me, I think that's one of the biggest as well. So I find that one really interesting as well. If ARC can survive all the things that are happening with it, we may learn more from them in the near future about what they thought about CRPs as a safety intervention. So I'll end there and just say thanks for your attention. There's some resources here, the organizations I work with. Email me with any questions. I'm thankful for this opportunity to come and chat with you all. I'm looking forward to our panel.
Well, thank you, Lauge. That was a wonderful presentation, wonderful research and a wonderful presentation. And we're really happy to now have really a reactor panel to discuss this a little bit more. So who do we have here? We have Michelle Anderson immediately to my right. Michelle is a registered nurse with over 30 years of service, including decades at the surgical trauma bedside. Now she is gently retired, which I love. I love that. I love that phrase. She's a practicing empathic patient advocate connected with PFAC, all of us, and other endeavors elevating the healthcare experience. To her right is Linda Kenney, who's the director of peer support programs right here at the Betsy Lehman Center. As a result of a personal experience with a near fatal medical event many years ago, Linda identified the need for support services in cases of adverse medical events and outlined an agenda for change. For more than 20 years, she's been encouraging organizations to tackle the challenges that impair effective communication, apology, and support programs for patients, families, and clinicians following medical errors and unanticipated outcomes. Sigall Bell is a physician researcher, healthcare innovator, and associate professor of medicine at Harvard Medical School. As director of patient safety and discovery at OpenNotes at Beth Israel Deaconess Medical Center and co-director of research at the National Collaborative for Accountability and Improvement, Dr. Bell's work concentrates on patient engagement, diagnostic safety, and equity. And she is, as you noticed, and I think as Lauge mentioned, is one of the co-authors on this study. So to get us started, I'm going to start with Michelle and ask the same question of Sigall and Linda. And it really is kind of picking up on that last Slido that the whole group answered. But just what do you think is, for you personally, what do you think the most important takeaway is from this study? What resonated?
Thank you, Barbara. Sidebar, I want to explain what gently retired means. Gently retired is when it was not in your wheelhouse. It was not the next thing to do, but it happened due to illness that was definitely not planned, but also a blessing in disguise. And I knew it from the onset of the illness. I didn't know what it was, but I knew that in the end it was going to be a blessing. So that's my definition of gently retired. And to answer your question, Barbara, with what information we just received, it's a duh moment for me. Like, duh, don't we know that? So perceived or not, if I think I've been harmed, there is some form of emotional distress. And emotional distress to me equals a hot mess. It's a hot mess because now you've shattered my belief that you are here to provide me with something that's going to improve my existence. You've increased my disbelief that I can trust you. And then from there, I can't think anything else because the person who I'm going to, this entity that I'm going to provide a service to me, I don't have confidence because I don't have trust.
Great. Okay, thank you, Michelle. I'm going to jump over to Sigall. Oh, sure. Those are my instructions, so.
Those are my instructions.
Are we on? Hi, it's a privilege and a pleasure to be here today with all of you. What I took away from the study is just sort of sitting with the gravity of how important this problem is to patients and families, and to organizations, like how important it should be to organizations, the prevalence of it, the significance of it. And the reason I say that is that we're trained as clinicians and as healthcare systems to deal with the problems that are in front of us when patients come to our facilities. But what's striking about this one is that this problem, because it's prolonged and happens outside of our hospital walls, is much harder to see. So there's this thing that's happening in our communities. You can't see the patients who don't show up to care because they lost trust in our healthcare system. And so I think this is really a call to action. It's funny, when I walked into the building today, I don't know if you guys saw this. I'm going to pull up the picture I took. There was a quote on the entry wall, right? Yeah, Maya Angelou. Do the best you can until you know better. Then when you know better, do better. It was like karma, right?
Linda?
I was the one that said nothing, because, patients and families have been telling us this for decades. This is nothing new. Lucian Leak once said, and I believe this, apologizing is, and doing the right thing by communicating is just not adding insult to injury. So none of this surprises me. I'm glad we have data to prove it, because that's been the missing piece. We have tons of data on how these impact clinicians, right? We don't have anything really except for these starting to come out on patients and families, and we need to do better, I'm thinking clinicians probably feel better because if they have organizational structure to be able to do the right thing. I remember years ago hearing from physicians saying, I want to do the right thing. I'm told to not talk to them. When we have these events, the old time clinicians had these things with them for years. The patients do too. There's no difference. It's almost like we go through the same thing on different sides, and we need to do better. I mean, we're lucky. We have a program here in Massachusetts. We're training. I would ideally love to train patients from an organization who have been harmed, who can be peer supporters to those others, but know the organizational resources better than I would, because I'm not there. But we do have peer supporters. Michelle's going to be one too. She's getting trained in the fall. We've hooked her. So, but we need to do better. And I know, so 25, Jesus, I'm getting old. 25 years ago, I had an event that nearly took my life. And that physician reached out and wrote me a letter, which was unheard of at the time, and we still work together. We're still good friends. The organization was a different story. But I know that meant a lot. And I can tell you, my family is still impacted by that event 25 years ago. Barbara knows, when I'm in the hospital, my family breaks down. Except for the youngest one, because she was only 3 at the time. So she has no problem with being the boss. So I just want to say this is, and I can tell you that I have gotten through all of those. In 2019, I had another event. It's just, I get this cloud following me around, but I wanted to say, I went through that disclosure process, which was amazing considering I didn't get any of that the first time. However, we need to do better because you cannot say to a patient, we're sorry that that the care that your expectations for care, it was like put on me. I'm like, so after, and two physicians said this. And so after I said, first of all, my only expectation these days is that you don't kill me. And number two, my next expectation is that don't ever say that to another patient again. And I know Jeff was on that and he goes, that went really well. And I'm like, it did, but there could have been some improvements. So that's the first thing I said is don't ever say that to another patient because I want to be part of the solution, not just part of the problem. So I'm sorry, I talked so long.
No, that's great. Thank you. Thank you. And Lauge, just really briefly, I mean, you've had an opportunity to, was there anything surprising to you? Any takeaways that you were not expecting from when you started out, or was it pretty much reinforcing what you knew?
I think it validated my experiences, but I was surprised at the strength of the use and just how much worse it was. I think for me, that was the unexpected piece.
Okay.
Can I just say one
Yeah.
thing? This is like with the eye towards being honest to the data, and I think Lauge mentioned this, that we were dealing with data that was already collected, so we couldn't ask the questions the way we wanted to. You'll notice that in some of the consistent with guidelines, there's, whole activities that should happen in open communication that weren't part of that survey and we couldn't ask about. But the one I want to just draw attention to and underscore, because I noticed a lot of people mention this as their take home, was that bad communication was worse than no communication. And I just want to put a little asterisk next to that, because that really depends on how the question was asked. And in our case, it was, no communication was, someone didn't disclose it, or the family, or patient didn't report it themselves. That's an unusual measure, right? That's an unusual way to say no communication. So I would say I wouldn't make that a clear take home in terms of going back to your organizations and telling people because this is terrible, this is what the problem is with missing communication after harmful events, that people are so afraid of saying the wrong thing that they say nothing at all. And that silence really compounds the harm, right? So I don't want people to walk out with this fear of, saying the wrong thing. I do want people to think about, how are we presenting this conversation to patients and families so that it is respectful. But I don't want to kind of put the kibosh on, having the conversation. So I just want to make a little note there.
Right.
I think it needs to be asked.
And Sigall, to your point, I believe, because I've been in this work, I believe that the conversation happened before they talked to me this is about managing the patient's expectation. I am sure that was said, so it was just turned around because they want to do the right thing. I'm not, it was just, it was just hit me the wrong way. So I think we just have to practice a little more beforehand. Okay, what are you going to say? What are you going to say? So with that, if they use wording that might trigger, you can say, you know what, maybe we should say it a little different.
Maybe we shouldn't blame the patient.
Really good point. So this is a question for Linda and Michelle. So you heard from Lauge that 85% of the time there was an outcome that was not expected, but maybe there was no finding of a real error behind it. So from kind of keeping that in mind, why, just from your perspective, your experience as patients, why is it important that providers communicate openly with patients who have experienced these unexpected harm events where at the end of the day there's the provider of the facility doesn't believe that there was an error? Why is open communication still important in that context?
I will first say in this instance, silence is not golden, right? My experience was such that backstory, I'm an RN. Backstory, I speak up for myself. One of my former biggest challenges was when it was time, Michelle, you're the patient, not the nurse. Stop working, sit still, be the patient. So in this particular instance, and this was back in 2015, I started having some health challenges, and I saw my doctor on a regular basis, who also was a part of where I worked. And at one point I said, I feel like we're dating because I had lots of appointments. The long story short, there was a need for a specialty. I needed to see a nephrologist. And I'll try and speed this up because I can go on forever. I asked to see a nephrologist. I asked for lab work. I was told, oh, you had lab work. No, I didn't. I asked you before, you said no. Okay, so now we get the lab work. The lab work results came after 5. But if you're my doctor and you've seen my labs trending in not the positive area, I would anticipate that you're waiting to see my lab results and that we could move forward. That didn't happen. My lab results came in late on a Friday. I looked at my lab results, and being a nurse, I know most of you are aware, we're still coming to work even if we're dead. If I can breathe, I can have a temperature, I can, whatever, I've got to go to work. And even dead, I'm still going to go to work because that's what we have to do. So I worked, even though I saw my labs, and I said, hey, kind of looks like kidney failure to me, but I only have to work this one shift, and I only have to. So finally, I got to the point where, yeah, Michelle, you need to check yourself in. And I still hadn't heard from my doctor, and it's now Monday. Remember, kidney failure? Yeah. I called only to ask if they could assist me in moving once I got through the emergency room. And I was told, can you wait? Can you wait until your PCP is available, which is tomorrow? I said, can you look at my labs? Did you look at my labs? Okay, so now I'm on the way to the emergency room because I put my nurse hat back on. Hi, kid, you need to get in. This is serious. I got a call from the covering nurse practitioner who was in a panic. Are you okay? Are you safe? Where are you? Can you get to? And I'm laughing to myself because I already have my packed suitcase in the car and I'm almost at the door of the hospital. During this process, though, I'm focusing on my health and my well-being. So I need to stay calm. I can't be upset about the fact that this should have been caught. This should have been caught early on. Why didn't you send me to a nephrologist? If this wasn't in your wheelhouse, why didn't you? These are the things that I'm tampering down because as I'm admitted and my blood pressure is 210 over 100 and something, that's not my concern. But I did my homework. I went in and I said, hi, I want to see either this or that nephrologist. I got admitted. And what's now happened because of this, I don't know if you want to call it a near miss or a complete catastrophe, but I've put on my hat of warrior and survivor, right? And so now this whole experience, I'm on the defense. That's not what this should be about. I have the upper hand because what? I'm a nurse and I'm in a place that I'm familiar with. And so I was able to facilitate my care as my discharging doctor said to me, who hadn't taken care of me during this experience, except for the day I was to be discharged. And she said, I don't know what to do with you. You're the nurse, the doctor, and the patient all wrapped up in one. And what I said was, this is what we're going to do. Because they were telling me I couldn't go home. Yeah, I'm going home. And I said, A, B, C, 1, 2, 3. Okay, I made it home. But during that whole experience, because from the onset, there is a breach of trust because I didn't feel that I was being cared for. I think I fell through the cracks. My PCP ended up calling me on my bedside telephone saying she was looking for me. Is that the care that we're providing? And so I get emotional because during that experience, all I kept thinking was how blessed I was to have the experience and understanding that the average person doesn't have. And so if you want to call it an error, if you want to call it a lack of communication, to this day, that doctor has not acknowledged their part in this experience. So is that a medical error? Is it a misstep? Is it a what? That doesn't matter. If you said to me, I am so sorry, that's worth $1 million. If you said you didn't know, I can receive that. You said nothing. So I want to say something so that you can hear, so that we don't have this problem again.
That's interesting, because I was asking about in cases where where there's harm but no error behind, and you're referring to more the sort of, I mean, it's not exactly a near miss, but you, because of who you were, avoided the harm, but there were a lot of missteps that you perceived, and I think and even you are a nurse and you're more tuned to it, but I think quite a few patients, many patients who don't have that clinical background also do perceive. I mean, they perceive the miscommunications, they perceive the kind of the chaos, and even if they come through it physically, maybe unscathed, it still can probably lead to some of the same distrust and other emotional harm consequences. So, Linda, do you have anything to add regarding
I think
that?
sometimes we don't have those conversations before surgery, or like I'm thinking surgery, yours is a little different, but we don't say, here are some things that we have you sign it, right? And you read all the things that can go wrong, but we don't really have sit down and have a conversation with the patient and say, here are the things that can go wrong. We don't typically have them, but don't worry if that happens. So that after surgery, you can say, by the way, remember that thing we talked about? It's not what we would like, but unfortunately, this is an outcome. I mean, we don't have those conversations. I always know that can be an infection, and I, just recently I had a doctor's appointment, and I think I mentioned this on the call. I didn't know who to feel worse for, me at the conversation we were having, or him, because I knew there was a hard conversation for him to have with me. Do you know what I mean? He's already amputated one leg and now he has to do surgery on another. He's not, he's not having fun. But
You need a tissue?
yeah, seriously, because at this point, we've been through so much together that, like, we talk about patient safety stuff and quality stuff, but I felt bad. But I feel like we don't do that with patients, so that after these things happen, they have an understanding. Do you know what I mean? And the worst part, I think, for me as a patient is telling care providers that something's wrong. I'm not a nurse, so I don't always have the vocabulary or the science, but I know something's wrong and nobody listens. And ultimately, yeah. I mean, I remember saying to my husband a Saturday night, I thought I gave everybody food poisoning at Barbara's house. I thought it was the food I made that made the pain. I said to him on a Saturday, hey, honey, how about after I take a shower, we have a date at the Faulkner emergency room? What do you think? So, like, I don't expect perfection, but I expect you to acknowledge when things don't go as planned and that it has upended my life for a year. Do you know what I mean? If I've got an open wound for a year and need another surgery a year from then, a 7-hour surgery, acknowledge that. Acknowledge. I just want to say, is Karen here? Oh, that's too bad, because I want to say she was at the Brigham at the time of that incident. And like, remember, 25 years ago, I didn't get that kind of thing, or 20 years before. Karen held my hand. She held my husband's hand. She cried with me. And I will tell you, that meant the world to me, that somebody gave about me. That made a difference. See, Alan, I'm doing better, huh?
Sounds right.
Okay, yeah.
So just, Sigall, from your perspective as a provider, any other thoughts to contribute? I'm sure you do.
Oh, yeah, no, the one thing that comes to mind is I teach communication skills after harmful events too. And, we'll show a range of cases. And one of them is like, was the scenario, it's like a late dose of antibiotic, and you might ask yourself, well, if it's 8 hours late, is it 6 hours to it? Like, where's the line where it's actually not the right care? And, the message from that case, which I think is the message here too, is that like, kindness and compassion, transparency, like these should just be our practice, right? It doesn't have to be like, the 6th alarm bell, fire, call in all the troops, let's have a full-fledged care response. Like this should just be the way that we deliver it. When patients are suffering, we meet them with kindness and transparency. Right, like that should just be universal. And I think that's very much what Melinda was telling us at the beginning in terms of the foundations of care. Do I have time to talk about?
I was just going to ask, how are we on time?
Okay, you have 3 minutes left.
Totally.
Right, you got
Okay.
it.
But go, Sheila. And we'll just wrap up.
Several years ago, we did a conference, an art conference, and Linda partnered with BIDMC. At the time it was MIPS, now it's under peer support here at Betsy Lehman Center, to do this conference to develop a research agenda to understand how to prevent, this emotional harm after harmful events for patients and families. And it was a hard conversation because it was many different kind of interest groups that were present, patients and families, clinicians, social scientists, foundation leaders. And these are hard conversations, right? Like patients and families who had lost family members, clinicians who feel fallible or who have this cognitive dissonance around, what do you mean I show up to work to do the right thing and there's these horrible outcomes. And so we were trying to think about how to have that conversation productively. And can someone grab the slides actually? So I'm gonna stand him if he can just advance those.
Which slides? Back to. It's during your presentation. Which slide?
The slides I sent you. Oh, okay. No, I'm gonna tell you all about them. Okay, so here's the story. We started the thing with a wall, like a gallery of 9 by 12 photographs. So imagine this entire room is just covered in photographs of, all different things, animals, people, nature, etc. And we gave people prompts, one of 6 prompts, like find an image that, has something to say about patient experience after harmful events. Find, an image that has something to say about listening. There were a number of different prompts. And everybody in the room grabbed a picture and then talked about it, in these small breakout rooms. And the reason I'm saying this, I wish we had the images, is that for me, these images are seared into my mind. They accompany the data that Lauge has told you about and the data that preceded this study with Julia Prentice's work here at Boston Lehman Center for the Massachusetts study. And it's things like a tortoise, like underwater, and the patient quote is like, we just feel like we're invisible. No one sees us. We're unseen. No one talks to us, and it's just this silence that we sit with, after this event. There was another photo of stadium seats. It was like the Red Sox stadium, and they're empty, nobody there. And the quote was, this is what it feels like because the providers, the organizations don't realize that a harm has happened. Like no one shows up because they don't realize that people are hurting in this way from what has transpired. Like they might say, and in answer to your last question, like it met standard of care, right? Check. We don't need to show up, but here is what's living on the other side of that. I think I'll stop there. There's a number of images that I think are really powerful ways to remember patient family voices and also clinician organization voices, but maybe you can find those online in the.
We can share them. We can share them.
Sure.
So I think we're, beyond time, so we're going to wrap up. I want to thank each and every one of you. I think this is a great discussion. The reason we're over was because it was so deep and impassioned, and I just want to sort of leave you with the thought that we didn't get to discuss as much. Really just remembering that one of the key findings, a really important finding from this research, is that the care programs, it's not, it's a patient, in fact, is a patient safety intervention in and of itself. It doesn't only prevent future medical harm for other patients, which is obviously extremely important, but it actually can prevent lasting emotional harm to the patient right in front of you. And that is just such an important value based on all of the emotional, the long-lasting emotional harm that we know from all of this research that does happen. So just leaving you with that, and thank you.
And Barbara,
Thank you
don't
again.
forget, patients, part of their healing is knowing that whatever fix is put in place will prevent somebody else from suffering the same harm. So and I think the clinicians too, to be able to have those conversations with the patient is healing somehow too, and we have to acknowledge that.
And there's actually data for that as well from the wisdom study, that physicians feel better or can process and have a better likelihood of moving toward wisdom after traumatic events if they're able to talk about it. So you're right. Yeah.
Great. So thank you.
Thank you. Thank you.
Yes, it's